The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Welcome to part 2 of the webinar series, Sex Ed Made Simple. Thank you for joining us today. It's so great to hear you all here at 3 p.m. on a Friday. This webinar here today aims to support educators, school district administration, and staff learn about sexuality education, what it is and what it includes, why it's important, and how to teach it. In part 1 of the webinar, we covered many topics, hopefully learning a bit and feeling more comfortable teaching and promoting sex ed. We covered many topics such as Oregon sex ed policy, teaching about consent, strategies for parent and caregiver engagement, and teaching about social media literacy. But we know that there are still so many more topics to go over, so we're happy to help you even more in part 2. Each webinar in this series will be hosted by myself, Sasha Grenier, with expert guest speakers. During the webinar, we will accept questions in the chat window and weave them throughout. So we really encourage you all to be engaged and type in the chat window or in the question drop down, and we'll try to engage with you as well throughout the webinar. If we don't get to answering all of your questions during the webinar, we will get back to you later with responses and resources. You will remain muted for the duration of this webinar. You can also find a recording of the webinars and all the ones from part 1 of the series as well on the Oregon Educator Network's Sex Ed site. Following the QR code on this slide, we will get you to that site. Or you can go to www.oregonednet.org/groups/sex-ed. Likewise, if this webinar gives you an interest in beginning further conversations with your colleagues across the state, please visit the discussion forum page on the Oregon Educators Network Sex Ed discussion forum. We can all continue the conversations there. Today's presentation will focus on teaching and understanding sexually transmitted infections, sometimes known as sexually transmitted diseases. We are very excited today to welcome Jillian Garay as our expert guest. She is the STD HIV prevention nurse consultant in the HIV STD TB section at the Oregon Health Authority. She has worked in the field of sexual and reproductive health for almost 15 years. She previously worked as a nurse at the Planned Parenthood of New York City. She was a research associate at Basic Health International, a nonprofit focused on cervical cancer prevention in Latin America. She has also worked at the New York City Department of Health and Mental Hygiene as a member of the School-Based Health Center Reproductive Health Project. Jillian earned undergraduate degrees in history and nursing at Rutgers University and a master's in public health at the CUNY Graduate School of Public Health and Health Policy. She relocated from New York City to Portland 1 year ago, and she still speed walks everywhere, but also now has an inflatable kayak. Yay, so Portland. And you know me, I'm Sasha Grenier. I am the Sexuality Education Specialist at the Oregon Department of Education. My role here at ODE is to support school districts in implementing effective sex ed that promotes health and safety among students across the state. So let's get started. First, a little recap. We know that sex ed plays an important role in promoting health and well-being. It has shown to be effective in improving academic success of students, preventing dating violence and bullying, and helping young people develop healthier relationships, delaying sexual initiation, reducing unintended pregnancies, as well as HIV and other STIs, and reducing health disparities among lesbian, gay, bisexual, transgender, queer, and questioning young people. Sex ed is about so much more than sex. It provides information to support young people to create and maintain healthy relationships, explore their own values and boundaries, understand their rights, understand their physical bodies, and seek health care when they need it. It's about building the social emotional skills that it takes to make healthy choices for ourselves and have respectful, fulfilling relationships with each other. We know that in this world that we live in, students are getting sex ed everywhere. From the time they look at their phones in the morning to when they talk to their friends, turn on the radio, use Google, you name it, sex ed is happening. In fact, a study from the American Academy of Pediatrics found that 75% of TV programs contain sexual content, but only 14 mention risks or responsibilities. If the sex ed, quote unquote, we get from media isn't mentioning risks or responsibilities, what do you think is missing? There's obviously a lot more information that young people need, deserve, and ask us for. And this includes for sexually transmitted infections, or STIs. We know that teaching about STIs can be a challenge. Here are some key teaching concepts that we will go through in more depth throughout this webinar today. First, it's pretty obvious that before having conversations about STIs, students and educators should understand anatomy and basics about infectious disease. Educators and students should also feel comfortable talking about genitals, sexual activities, transmission and prevention of STIs. We know this comfort level can take a while to build, but practicing the vocabulary is essential so that the classroom is a place that is free from slang and full of medically accurate information. This also helps to set the foundation for a safe classroom, making sure that everyone can engage with the material regardless of the student's sexual orientation, gender identity, cultural background, and life experiences will help students feel that they aren't being judged and can ask any questions that they have. And finally, one of the most important things to keep in mind is that the information per Oregon law cannot be fear or shame-based. In other words, we can't use tactics that motivate student behavior, that use scare tactics to motivate student behavior change. Showing the worst example of an STI photo to a class is an example of a fear tactic that many of us got in our early sex ed classes, right? I know I did. Those images not only don't work to change behavior, but they also spread misinformation. Students can incorrectly assume that those images demonstrate what STI symptoms always look like, but in fact we know that STIs are often symptomless and require testing, not symptom identification alone. So, how do educators do all this? The new Oregon Health Education Standards help guide educators to know what topics should be taught and when. You can see that information about disease prevention begins in health education as early as kindergarten. How, you ask? Talking about things like hand washing and healthcare, for example. These are the sorts of messages that will build the foundation for other topics later on. You can see in this table a short example of some of the health education standards that are required in health class. This is just a small pool of the standards, so please reference the complete standards on the ODE website. But you can see in kindergarten, for example, one of the standards is that students should list potentially unsafe body fluids and objects to avoid. In third grade, you see an example there. Explain why it is important to stay away from potentially unsafe body fluids and objects. And then in fifth grade, you see it getting a bit more mature. Discuss how abstinence is the most effective way of protection from STDs, HIV, and pregnancy. So you can see how it starts really basic, really elementary, and proceeds throughout following someone's development and cognitive abilities throughout their development and adolescence. So don't be too overwhelmed by all the standards just yet. I know there are a lot. Focus on the key concepts and repeat. We know that knowledge alone doesn't change sexual behaviors. We need to repeat to change norms, not just dispense facts. The core message that we want to focus on is abstinence and condoms. And condoms not just for contraception, but also for STI prevention. Shaping beliefs and attitudes about condoms is one of our most essential tasks. Engaging youth in comfortable conversations about these topics is a great way to do this. So we know that this approach works. Many research studies show that when we teach sex ed early and consistently throughout childhood and adolescence, outcomes improve. This is just a small collection of the research that's out there that shows that sexuality education works to increase condom use and lower STI rates. But there's a lot more out there. This is just a small snippet of the research. So now let's hear from our expert guest speaker, Jillian, from the Oregon Health Authority. She'll help us become more familiar with the facts and messages that will help us teach and understand STIs.
Thanks, Sasha.
Yeah, of course.
Okay. Sorry, just bear with me one moment.
You're good.
All right. Can you see the full screen?
We actually just see your presenter screen.
Okay, so sorry. Hold on one moment.
No worries. Just click the little icon at the very bottom of your screen that looks like a slide. There we go.
Oh,
same
still
thing.
wants to do that.
Okay, well, just go ahead and I'll move the slides forward as you progress. I'll take the controls back.
Okay, so sorry.
No worries.
Thought that we had that down. It's the 2-monitor problem.
Okay, go ahead.
Okay, great. So,
thanks for your patience, everyone.
Yes, so sorry. I'm so glad to be participating in this webinar series speaking about sexually transmitted infections in youth today. So, over the last 5 to 10 years, there has been a dramatic surge in sexually transmitted infections nationwide. Oregon has experienced this increase as well, and adolescents and young adults are not immune. In this webinar, we're going to review the prevalence of STIs among youth nationally and in Oregon, discuss state policies regarding STI services and minors, explore the various factors that impact STI rates among adolescents, demystify STI medical care, and provide inclusive messaging about sexual health. So I just said STI a lot, and many of you may not be familiar with that abbreviation or may be confused about the difference between STI, sexually transmitted infection, and STD, sexually transmitted disease. These are often used interchangeably, and I will probably slip and say STD at some point during this presentation. The difference is that infections are only considered diseases once someone starts showing symptoms. But many people who have a sexually transmitted infection do not show symptoms. So someone can have an infection without having symptoms of disease, and the only way to know for certain if someone has an STI is to be tested. Another reason to use the term STI instead of STD is to reduce stigma by moving away from thinking of these as disastrous diseases and toward approaching them as treatable or manageable infections. So, which STIs are we talking about today? Well, I work in the HIV-STD program, and we focus on the 3 bacterial STIs, chlamydia, gonorrhea, and syphilis, as well as HIV, which is, of course, a virus. Chlamydia is the most common reportable condition in the U.S., and by reportable, I mean a condition considered to be of great public health importance. Gonorrhea is the second most common reportable condition, and both chlamydia and gonorrhea can cause serious complications if untreated. Just as a side note, one of the reasons gonorrhea is of such concern and why you may have heard news reports about it recently is that there is only one highly effective antibiotic treatment remaining. Finally, syphilis and HIV are less common, but having any STI can increase a person's risk of becoming infected with HIV. These graphs show the change in national STI rates between 2013 and 2017, just among 15 to 19-year-olds. The rates are the y-axis on the left, and you'll notice they differ dramatically between the 3 STIs, with chlamydia at the top left having a very high rate ranging between about 1,900 and 2,100 cases per 100,000 people, compared to a single-digit syphilis rate, but rates are increasing across the board. 2017 marked the 4th consecutive year of sharp increases in these 3 STDs. Okay, so now let's look just at Oregon. In 2017, there were 4,730 chlamydia cases reported among adolescents aged 15 to 19. In the graph on the left, the bars show the number of cases at each year of age, with the dark blue on the bottom representing males and the light blue females. The graph on the right shows the rate of cases, and we can see the distribution of cases by age group. We're focusing just on the 2 age groups to the left in that graph, and the red bars denoting females show that the rate is highest for 18 to 19-year-olds, so that bar second from the left. We'll talk more in a minute about why STI rates appear to be rising, but I want to mention here that women tend to be screened more often than men because of more frequent use of health services related to sexual and reproductive health, and annual chlamydia testing is recommended for all sexually active young women. So part of the reason for the rate we see here is that more women than men are tested at these ages. So, in 2017, there were 303 gonorrhea cases reported among adolescents 15 to 19 in Oregon. We can see that there is less of a difference between rates among men and women than there were with chlamydia. This is partly because men with gonorrhea are more likely to have symptoms and to seek testing, driving up their share of cases. You'll also note in the graph on the right that the rate is higher for women aged 15 to 19, but that switches after adolescence. A significant percentage of gonorrhea cases is attributed to gay men or men who have sex with men, which is also a contributing factor to the higher rates among men after adolescence. This graphic is another way of looking at the proportion of new STI cases affecting young people, with the purple color representing those aged 15 to 24. It's important to remember that STIs are common, treatable, and preventable, and that people of all sexual and gender identities are affected. So there are several reasons for the recent rise in STI rates. Some of these are listed here. First, there is likely an increase in the number of infections occurring. There may also be an increase in the number of people being tested, which is leading to more diagnoses. Testing itself is easier now that people can give a urine sample instead of being tested with an uncomfortable swab, and there's more testing of other sites of sexual contact, like the mouth and rectum, which is also leading to more diagnoses. Lastly, the newer testing technology is better at detecting infections. Fear, stigma, and misinformation can make it difficult to talk about STIs. Just knowing a few basics can help alleviate anxiety by increasing familiarity. This slide explains the basics of chlamydia. People may not know that they are infected because there are typically no symptoms initially. The most common test only requires a urine sample. The infection is cured with 1 dose of an antibiotic taken by mouth. Without treatment, the infection can cause pelvic inflammatory disease, or PID, in women and lead to problems with fertility and pregnancy. Prevention of PID is also why annual chlamydia testing is recommended for sexually active young women. And here are some gonorrhea basics. Women usually don't have symptoms, but most men have the classic drip or discharge from the penis. Gonorrhea testing is also done with urine, and chlamydia and gonorrhea tests are usually done together. The infection is cured with an injection of that highly effective antibiotic I mentioned earlier, and 1 dose of an antibiotic taken orally. As with chlamydia, untreated gonorrhea can also cause PID and lead to fertility and pregnancy complications. The testing and treatment for these extremely common STIs is straightforward and relatively simple. So let's dig into some of the reasons why STIs are common among adolescents and what contributes to their risks. So young women are susceptible to STIs because of the presence of a certain type of cells on the outer surface of the cervix inside the vagina. As women age, their anatomy changes and there are fewer of these cells on the outer surface, so the risk related to this vulnerability decreases. The higher susceptibility is another reason why annual chlamydia screening for young sexually active women is recommended. The logistical barriers are the ones we tend to think of when we delve into why adolescents may delay or avoid seeking sexual health services. Even if adolescents are covered by a parent's insurance plan, they may not have access to that information, or they may be concerned that the insured parent will find out about the visit. Paying out of pocket is often not an option for young people, and they may not be aware that low-cost or free services are available. In addition, clinic hours often conflict with the school day. Young people may also not have easy access to transportation to get to the clinic, and of course there is the ever-present concern of other people finding out that they went to a clinic for STI testing or that they have an STI. The impact of stigma and confidentiality concerns on the likelihood that adolescents will seek sexual health care cannot be underestimated. Research shows that a quarter of sexually experienced adolescents aged 15 to 17 would not seek sexual or reproductive health care because of concerns that their parents may find out. We see the results of these concerns when we look at a few health promotion measures. Young women who do not have confidentiality concerns are more likely to be screened for chlamydia. Adolescents who are given an opportunity to speak with a medical provider without a parent present are more likely to have a sexual risk assessment, and these women are also more likely to be screened for chlamydia. Finally, males with public insurance or no insurance are more likely than those covered by a parent's insurance to undergo STI testing. Under Oregon law, anyone under the age of 18 is considered a minor. There is no explicit right to confidentiality for minors or right to disclosure for parents written into the law in Oregon, and federal law may offer additional confidentiality protections. Minors are legally allowed to receive testing and treatment for STIs, including HIV, without parental consent. Medical providers use their clinical judgment in deciding whether to share information with the parent. Oregon law protects medical providers when a diagnosis or treatment is provided to a minor without parental consent. I also want to mention that there is an Oregon law that allows individuals to request to have protected health information, such as an explanation of benefits, sent directly to them, instead of to the person who pays for their health insurance plan. This may be of particular benefit to minors concerned about confidentiality of sexual health services. A link is included at the end of the presentation to find out more about that law. Okay, throughout this talk, I've referred to females and males, women and men. We often use those terms because they're easier to understand, but when we're talking about sexual health, what we're really talking about is anatomy. So instead of saying females or women, it would be more inclusive to say people with a cervix or vagina, and to say people with a penis instead of males or men. This is because not everyone with a cervix or vagina identifies as female, and not everyone with a penis identifies as male. So when we use those terms, people may feel excluded or invisible. We are all becoming more aware of how gender identity is not tied to anatomy, but instead relates to a person's internal sense of being a man, a woman, both, neither, or another gender. The gender unicorn here is a handy tool that was developed to show that gender identity may not be the same as the sex someone was assigned at birth. A person's gender expression may not match their gender identity or sex assigned at birth, and sexual identity or sexual orientation is about who someone is attracted to, separate from gender identity. When you're teaching about sexual health, using anatomy-based terms is a more inclusive approach than referring to women and men, even if it feels clunky and uncomfortable at first. Recognizing non-heterosexual relationships will also allow more students to feel seen and included. These are some common and less common terms that people may use to define their sexual orientation, but there are many, many more showing the diversity of sexual identities. It's important to recognize that the term someone uses to describe their sexual identity may not match their sexual behaviors. For instance, someone who identifies as heterosexual may in fact have sexual contact with someone of the same sex, and a person with a cervix who identifies as lesbian may have sexual partners with a penis. The most recent CDC Youth Risk Behavior Survey, or YRBS, showed that high school students who identify as gay, lesbian, or bisexual are more likely to report having ever had sex compared with students who identify as heterosexual. Of note, more than a quarter of high school students reported that they were not sure of their sexual identity. The prevalence of many health risk behaviors is significantly higher among sexual minority students, and students who have sexual contact with both sexes are at higher risk than students with only same-sex sexual contact for multiple sexual risk behaviors. These risk behaviors include having ever had sex, having had sex before age 13, having had sex with 4 or more persons, being currently sexually active, not having used any method to prevent pregnancy, and having drunk alcohol before sex. The higher risk of no condom use among males with only same-sex sexual contact compared with those with only opposite-sex sexual contact is concerning because of higher HIV/STD risk among gay men. STI risks are higher for gender and sexual minorities. There are high rates of the STIs we've discussed today among men who have sex with men. Transgender women are at higher risk for HIV and STIs compared to others. People of color, particularly men, are less likely than white men to disclose same-sex partners. And sexual minorities may experience sexual violence and may be at risk of STIs as a result. It's important to recognize that non-heterosexual teens, those who identify as lesbian, gay, bisexual, queer, or another identity, are especially at risk if their sexual or gender identity has cost them their family or community, and they engage in sex for money or for housing, food, or other life necessities. As I mentioned earlier, STIs are common, treatable, and preventable and can affect anyone. The best prevention is no or low-risk sexual contact and condom use with every sexual act. In conclusion, while discussing sexual health with youth may occasionally be uncomfortable for everyone involved, they will benefit immensely from open communication with trusted adults and inclusive, non-judgmental discussion that recognizes the spectrum of identities and sexual and romantic relationships. I've included a couple of helpful resources, including that Oregon law I mentioned earlier. There's a great link on the CDC webpage that discusses condom effectiveness and has how-to graphics as well as fact sheets available. Advocates for Youth is a wonderful organization that put together a K-12 sexuality education curriculum called Rights, Respect, Responsibility. And GLSEN issues a report called Supporting Safe and Healthy Schools for Lesbian, Gay, Bisexual, Transgender, and Queer Students, a national survey of school counselors, social workers, and psychologists. And they have state profiles that detail LGBTQ health in every state. Thank you.
All right, everybody. Thank you so much, Jillian. That was awesome. We want to spend a few minutes now taking any questions that folks may have. So please feel free to type those in to the question area or to the chat area, and we'll get to those. We have quite a few minutes to discuss anything that you would like. So just glancing at those now, there are a few questions. One person asked, what about insurance? This is for you, Jillian. That is billed to parents. I presume this question is about confidentiality and the payment process for insurance and visits to a doctor or provider.
Yeah, so that's a very common question, and it's honestly a legitimate concern. This is part of the reason why that law that I mentioned was passed in 2015 to redirect the explanation of benefits that is usually sent to the insured person describing the services that were rendered under that insurance plan. It's not a fail-safe because I don't believe that there is a guarantee that no information about a visit for sexual health would be sent to the person who the insurance is under, but it would redirect anything with personal health information. So anything specifically related to the services that were obtained can be sent by email, by phone, to another address of a teenager or young adult who used the insurance but wanted to be sure that their confidentiality was maintained. But it's definitely something to look into regarding the personal needs of the individual involved.
Great. Thank you, Jillian. One more here from a participant. Can you please give an example or an explanation of low-risk sexual contact?
Sure. So what I mean by that would be something like mutual masturbation. So rather than, let's say, vaginal and penile penetration, mutual masturbation would lessen the risk of contracting an STI. Of course, there's always some risk of transmission of an STI with sexual contact, but that is one way that is considered low risk.
Thanks, Jillian.
Mm-hmm.
Here's another one, even though there isn't a right, quote unquote, for confidentiality for minors, isn't that the practice?
Yes, excellent point. So there is an expectation of confidentiality, partly reinforced through popular culture and just our understanding that conversations with medical providers are typically confidential, depending on what's being discussed, whether there are issues of safety involved. That's why it's not a given per se in Oregon that whatever is disclosed will remain confidential, just because especially when it comes to minors, if there is a true safety risk or something that the provider deems necessary to involve a parent or guardian or social services or law enforcement around, then that that so-called right to confidentiality would not necessarily be upheld depending on those circumstances.
Thanks. Do you have any thoughts on condoms being handed out at a school health room and readily available like Band-Aids?
Do I have thoughts on that? I am an STD HIV prevention nurse, and I do believe that harm reduction is an essential tactic in making sure that youth stay healthy, and also realistically that sex happens and that youth, adolescents, young adults have sex. And so to ensure their health and safety, I think that there is a place for condoms in school-based health centers.
And I also would like to add, based on that, if we're looking at the health education standards, condom demonstrations and describing how condoms work are required as part of Oregon's health education standards starting in 6th grade. So it would make sense also to have some availability, or at least some, seeing those and how they work in a hands-on sort of way to be able to apply those skills to real life. So in terms of age appropriateness, using the health education standards as a guide, we know that condom demonstrations and condom availability is something that youth ask for and need to be safe and healthy. Are there any other questions out there? I'm wondering if any educators that are on the call want to share maybe what practices they've used or things that have worked for them that they could share with their colleagues also on the call. Is there any practice or lesson or discussion point or question that they've found especially resonates with the young people that they teach? Could be at any grade level, whether it's elementary, talking about other things like hand washing and what objects are safe to touch versus not touch, or middle school, talking about condoms, or throughout the grade range throughout high school. Has anything worked for you all, or? I know that talking about condoms has been something that we tend to get many questions about, so I would love for other examples to come up to help each other. We have one participant chiming in saying that explaining the different testing options and testing resources in the community as being important. Totally, that's a great one, actually connecting to places that are accessible in a student's own community. Is really important. Thinking about things like transportation and how folks can get somewhere for testing is also things to keep in mind. But bringing it really local, that's a great point. Thank you for that. And just building that level of trust among students and educators so that they can ask those questions and you can play that role of the trusted adult in the room and perhaps even their lives that can provide answers to some of their most important questions, and then resources to the community nearby is great. Does anyone have any other questions? Oh, we have another participant. Let's see, we use the condom lineup a lot, which helps a lot. We also make sure to pass the condoms around the classroom so that the students can touch them and destigmatize using lube. Yeah, that's a great one. I mean, just starting to really feel what they feel like, and see them firsthand, so that they don't seem like something really foreign, really kind of mythical, right? That no, they're in a classroom. We know how to use them, and here are some ways to do it. We have another comment. I'm an educator that works with middle school and high school students. When I talk about STIs, I usually try to do a destigmatized conversation where we talk about ways to reduce stigma by normalizing testing, supporting a friend who goes out to get tested, and not judging people who have STIs. Yeah, just becoming aware of how we talk about it, making sure that everyone feels like, it's something that we're not alone in experiencing. Like Jillian had said, they're common and they're treatable, and people around us are experiencing similar things. So that's a great point. Thank you. We have one more. We also talk about oral barriers at the high school level. That's another important one, that when there's also, dental dams and things that can be used when performing oral sex, that also require or should be used, protection should be used during that as well, which is also something that generally doesn't seem to be a major focus of education, but I'm glad that we have some folks in the call here that have experience using instructional methods to show about those, so that's great. Another thing to work towards is eliminating language like clean or dirty. This is such a common language for discussing STI infections. Absolutely, just changing that works to destigmatize, right? Changing just the words that we use to describe an infection, and management of an infection, versus more kind of very demoralizing, very dehumanizing sorts of words when we talk about STIs. Thank you, everybody. That's great. Well, we can start wrapping up. Jillian, did you want to add any final comments, thoughts, answers, or thoughts regarding some of these comments that we've had come in?
I'm just really thrilled to hear that people are working to destigmatize STIs and becoming just more comfortable talking about these issues, especially with younger adolescents. My talk focused a lot, of course, on high school age, especially later high school age, because we know that 18, 19-year-olds are more likely to acquire an STI than those at younger ages. And I didn't report this in the presentation, but there are cases of STIs, certainly among the younger ages, 13 and 14. So it's really great to hear that people are talking about condoms and destigmatizing and just making it just a part of the conversation regarding sexual health and really just health in general, because sexual health should just be thought of in terms of staying healthy overall. So very excited for the work that's being done in schools.
Thank you. Thank you. I also want to add, even though the people in older age ranges in high school are the ones most susceptible to infection, the prevention to build these skills to, later seek the health care that they need, use condoms, all of those skills start really early. Those skills involve kind of self-management, control over one's body autonomy, those sorts of pieces, communication, being able to ask questions about your body to adults, all of those skills we start very early, and it doesn't have to be talking about sexuality, but instead is talking about how to recognize when something doesn't feel right and how to proceed when something doesn't feel right. Who do you talk to? Who's a trusted adult to talk to? My body is my body. These are the parts of my body. Using those anatomically correct terms that we talked about in the beginning is really important, so that young people can describe to an adult what they're feeling and where they're feeling it, rather than using slang or things that adults can't understand. So yes, although the prevalence is much later, those skills begin very early. So Thank you all for joining us today. We would love to continue the conversation with you on the Oregon EdNet Sex Ed group site. And again, I got fancy and used a QR code that's on this screen right here. They were new to me until a colleague showed them to me, so you can just take a picture of it and it actually goes to the website on your phone automatically. So it's super helpful. Feel free to join that group and be involved in those discussions that are happening there. And again, all the recordings from these sessions will be available there as well. And yet I'd like to remind you all too that our next Making Sex Ed Simple, Sex Ed Made Simple, will be on February 22nd, so the last Friday of the month from 3 to 4. And we'll continue in that same schedule throughout the rest of the school year. So join us that day for the Teaching Culturally Inclusive Sex Ed, and we'll continue then. All right, so everyone have a wonderful rest of your day and enjoy your weekend, and we hope to hear from all of you soon. Thank you, Jillian, again for joining us. It was really wonderful.
Thank you.
Thanks, everyone. Bye-bye.